Hey everyone, it's Dr. Marcon. This is part 2 of chapter 17 on the endocrine system. So now we're going to get into the different disorders. We just finished talking about diabetes mellitus, and now we're going to talk about disorders of the thyroid gland. So the first disorder we're going to talk about is Graves' disease. Graves' disease is the most common type of hyperthyroidism. So hyperthyroidism is basically an increase amount of thyroid hormone. One of my roommates from medical school, actually my best friend from medical school, she actually had hyperthyroidism, and she definitely exhibited a lot of the symptoms that we're going to talk about. So Graves' disease occurs when the immune system makes abnormal antibodies and stimulates the oversecretion of thyroid hormone by the follicular or follicle cells in the thyroid gland. This leads to nervousness, weight loss, sweating, and rapid heart rate, basically an increase in metabolism. I mean, she would just walk up the stairs and she had heart palpitations with an increased heart rate. And she definitely would be sweating. She had lost a lot of weight, and this is all due to her hyperthyroidism. The next disorder, going the other way, is myxedema. Myxedema is adult hypothyroidism. So basically, the antibodies will attack and destroy thyroid tissue. This will cause a low metabolic rate and weight gain, which are common symptoms. So basically, your metabolism has decreased due to the decreased amount of thyroid hormone. Another disorder is endemic goiter. Endemic goiter is due to a lack of iodine in the diet, and this usually occurs in third world countries. Or that is why a lot of times when you buy salt, some of the salt companies or companies that sell salt make sure to put iodine in the salt to make sure you're getting the adequate enough amount of iodine in your diet, because if you didn't have iodine in your diet, you wouldn't have formation of your thyroid hormone. Iodine is a very important molecule for the formation of thyroid hormone. Creatinism. Creatinism is a hypothyroidism in children. Myxedema was hypothyroidism in adults. Creatinism is hypothyroidism in children. These patients will exhibit short, disproportionate bodies, thick tongues, and also mental retardation. So here are actually a couple of the symptoms of the different thyroid disorders. Here we have what's known as exophthalmos. So exophthalmos is due to hyperthyroidism. So this is a woman with hyperthyroidism. You'll see protrusion of the eyeballs as a symptom, and you can see that her lower eyelids are pushed downward by her bulging eyeballs with a great deal of the white showing. And there are numerous tiny blood vessels in the whites of her eyes. So this is exophthalmos. The next disorder you'll see is goiter. So you'll see an enlargement of the thyroid gland that almost looks like a tumor. This is a woman with an enlarged thyroid gland or goiter. The goiter is visible as a swollen bulge in her frontal neck due to iodine deficiency. So here we see that goiter there, and this is due to hypothyroidism. Next, we'll go into the disorders of the adrenal cortex. A very well-known disorder is Cushing's syndrome. So Cushing's syndrome is caused by hypersecretion of glucocorticoid hormones, usually due to a pituitary tumor. So this is due to a hypersecretion of the ACTH hormone secreted by the anterior pituitary gland. So again, there are many symptoms that characterize Cushing's disease. So usually you'll have high levels of glucose in the blood, loss of protein from muscles, and lethargy, and this can lead to water and salt retention, resulting in hypertension and edema. Another disorder of the adrenal cortex is Addison's disease. Addison's disease is a hyposecretion or hyposecretory disorder of the adrenal cortex. You'll usually have deficiencies of both mineralocorticoids and glucocorticoids, namely, mostly you'll have a deficiency of cortisol, and maybe just often maybe a little bit of a decrease in the amount of aldosterone.
So here you can see the effects of excess glucocorticoids. So the first photograph shows a healthy, slender woman seen in profile. The second photograph shows the same woman also in profile view, but with visible symptoms of Cushing syndromes. We have moon faces, so basically her face kind of looks swollen, so her face and neck are noticeably swollen, and she exhibits the characteristic buffalo hump of fat in her upper back. Her hair also appears coarse, and this is due to excess glucocorticoids. So the endocrine system throughout life, the thyroid gland forms from a thickening of endoderm on the floor of the pharynx. The parathyroids and the thymus gland will form from the endoderm lining the pharyngeal pouches. This is during embryonic development. The pineal glands will originate from the ependymal cells. Pituitary gland is actually of dual origin, so it has two different origins. The anterior pituitary gland, or the adenohypophysis, originates from the roof of the mouth, whereas the neurohypophysis grows inferiorly from the floor of the brain. The adrenal gland also has dual origins. The adrenal medulla, the inner part, will originate from neural crest cells of nearby sympathetic trunk ganglia, whereas the outer adrenal cortex has its origin from mesoderm lining the coelom. So here you can see the embryo at week 5. We can see that the thyroid, thymus, and parathyroid glands will form from the pharyngeal endoderm. So we have different parts. So here we have the pharyngeal endoderm forming the future thyroid gland, parathyroid gland, and thymus. Whereas the hypophyseal pouch extends superiorly from the ectoderm in the roof of the mouth. So we have a neurohypophyseal bud that will form eventually the posterior pituitary gland. And then here at week 6, the inferior extension of the floor of the diencephalon forms the neurohypophyseal bud, which will eventually participate in the posterior pituitary gland. So here we see that bud. By week 7, the hypophyseal pouch pinches off the surface ectoderm and is closely associated with the neurohypophyseal bud. And then week 8, the hypophyseal pouch forms the anterior lobe of the pituitary, whereas the neurohypophyseal bud forms the posterior lobe of the pituitary gland. And we know that the distinct portions of the pituitary gland each differentiate. So that's why the anterior lobe is distinctly different from the posterior lobe, especially with the different hormones that are produced. So endocrine organs operate effectively until old age. The anterior pituitary gland will increase in connective tissue and lipofuscin, you'll see a decrease in vascularization and a number of hormone-secreting cells. The outer adrenal cortex, normal rates of glucocorticoid secretion continue. Adrenal medulla, there are no age-related changes in our catecholamines, or epinephrine or norepinephrine. With our thyroid hormones decrease slightly with age, so you'll have a decrease in metabolism. Parathyroid glands, there's very little change with aging. They still monitor the levels of calcium in the blood. And then your GH, DHEA, and the sex hormones, you'll see marked drops in secretion with age. DHEA being dihydroepiandrosterone, produced by the adrenal gland, helps produce other hormones including testosterone and estrogen. So we know that growth hormone, DHEA, and sex hormones, again, will definitely see significant drops in secretion with age. So you guys, that is it for the endocrine chapter, chapter 17. So we finished up with the disorders of the different endocrine glands. Okay, and that is it.